I'm Alan Venook. I'm a medical oncologist at the University of California, San Francisco. It is my privilege to present this analysis of CALGB SWOG 80405, the impact of primary tumor location on overall and progression-free survival in patients with metastatic colorectal cancer. I'm presenting on behalf of the Alliance for Clinical Trials in Oncology, formerly the CALGB SWOG, and the United States Intergroup with members from United States and Canada. As you recall, the original design of CALGB SWOG 80405 was in unselected patients with metastatic colorectal cancer who could have received one of three chemotherapy and biological combinations, FOLFOX or FOLFIRI, with or without, with cetuximab, with bevacizumab, or with the combination. The FOLFIRI or FOLFOX was chosen by the physician. Ultimately, the study results were presented in 2014 at ASCO with an amendment that accounted for the patients to be just KRAS wild type at codons 12 and 13, and just two arms, in fact, rather than three arms. The two arms were chemotherapy cetuximab and chemotherapy bevacizumab, and there was no difference between the two treatments. Subsequently, we reported at ESMO updated results now with an all-RAS wild-type analysis, 526 patients, chemo cetuximab 32 months, chemo bevacizumab 31.2 months. There was no difference. At that time, certainly the results were much better than we'd expected when we designed the study 10 years earlier. Part of that was treatment, and we knew part of that was patient selection. We don't do a very good job of selecting patients and hadn't done much of that for years. We sort of thought of it, the colon as just a tube, a 6-foot-long tube. We now know that it's a complicated tube. KRAS and any RAS mutations, consensus transcriptional subtypes have been described across the colon, and there's some things that tend to be on the right side, BRAF mutations, hypermethylation, and patients with unusually poor prognostic clinical disease, women with peritoneal disease on the right side. We shouldn't be surprised that the right and left colon are different. If you think about the embryology, the right colon comes from the midgut and the left colon from the hindgut. With that in mind, and based on some small publications or older publications, a publication is, in fact, back in 2001 that saw a difference in left versus right overall survival in patients with metastatic colorectal cancer, we endeavored to determine if there was a difference in results in our study. The site of the primary tumor had not been something we'd captured in the original data set or in the case report forms. Our methods involved looking in the population of patients who were KRAS wild type, as well as a pre-amendment KRAS mutant population. We extracted the data, and only certain results were recorded. If we couldn't really make an absolute determination of the primary side, we did not declare it. As it turned out, we had 732 patients who had left-sided primaries, 293 with right-sided, 46 we couldn't determine, and 66 were in the transverse colon. When we applied the transverse colon patients and their data to either the left or the right side, it did not make a difference, so we excluded those patients from this analysis. As you look at the patient characteristics, indeed, right and left-sided disease was a bit different in this study. Patients, even though it was a very young group overall, were slightly older in the right-sided group. Many more patients had synchronous stage 4 disease on right versus left, although the vast 79% overall in the entire study had synchronous disease. The primary was left in place on the left side more often than the right, and the liver was a dominant site of disease more so on the left than the right, as you see on the statistics. The results are shown in the next three slides. The patients with left-sided disease had a 33-month plus overall survival compared to 19.4 months on the right side. The bevacizumab patients did better, but most dramatically, the patients with cetuximab with left-sided disease had a 36 versus 16.7-month overall survival, p less than 0.0001. Progression-free survival also favored the left versus right, and the cetuximab patients also did much better on the left versus right. If we go back to that 19.3-month difference between the left and right side with cetuximab, that seems like a very big difference. But when you look back at FIRE3, which has reported in a variety of settings different results based on different analyses, in this analysis with a RAS wild-type all RAS wild-type population, there was a 7.5-month benefit of cetuximab over bevacizumab. That's different from our study, but the patients receiving cetuximab on the left side versus the right side looked very similar to what we saw in 80405. In the FIRE3 analysis, smaller numbers, but 38.3 versus 18.3 months survival, left versus right. When we looked at the sidedness by logic interaction, you see that, in fact, the left side, cetuximab versus bevacizumab, was statistically significant with a p-value. Right side was not quite statistically significant for bevacizumab over cetuximab, but in fact, the hazard ratios are a bit more robust on the right versus the left. This is sort of a time where the hazard ratios and the p-values say slightly different things. In each case, there's a difference, although not dramatically so, as certainly on the left side. This slide shows the overall survival by sidedness and by logic, and you see the best group on the far right, the red, the worst group on the far left, the pink. In fact, that's cetuximab on the left versus cetuximab on the right. And then the next two slides show just the individual groups, left versus right side. Clearly, the conclusion is that this is prognostic. Sidedness is prognostic. Patients with left-sided primaries do better, and predictive because there are differential effects based on subgroups as defined by sidedness. And the side is not magical. It's a surrogate for molecular features, and we're in the process of working that out in great detail with an exhaustive molecular biology analysis of patients' tumors and blood. BRAF, for example, is on the right side. That's not enough to account for the differences, but many other things are being looked at, including the transcriptional subtypes as have been described elsewhere, hypermethylation, and epiregulin and ampiregulin. Other things we won't be able to assess are the immune system and microbiome. The limitations of this study, it's only first-line therapy that was specified, and because it wasn't pre-planned, we couldn't control for imbalances. And of course, I've only told you about the KRAS wild-type patients. If we looked at the KRAS, a subset of the KRAS mutant patients, we also see that there tended to be left-sidedness better than right-sidedness survival, suggesting it's consistent, although these numbers were smaller. There was one unusual subset, patients with the right-sided cancers, those with wild type who got cetuximab surviving 16.7 months, those with mutant KRAS getting cetuximab 23.3 months. This seems upside down, and if this is true, we know less about RAS than we think we do. Finally, the take-home message is sidedness is a surrogate for tumor biology, and the side of the origin of the cancer matters. Now, what will I do with these results? Well, I believe that sometimes retrospective data is enough to change the way we treat patients. This is a very tough call. I believe for now, the leaning would suggest that cetuximab is not helpful on the right side. But again, different people will come up with different conclusions. Hopefully, when we sort out the biology underlying this, we'll come up with a more definitive answer. Thank you for your attention.